Hi, thank you for meeting with me today. My name is Stephanie Ramirez, and I'll be presenting a 6-month progress review for my client, Alex Rivera. I will cover referral behavior, function, treatment strategy, skill acquisition, data, treatment integrity, and next step recommendations. So I'll walk through each area, one section at a time, with data visuals and ethical alignment wherever relevant. With that being said, let's start. So the client is Alex Rivera, and I would like to preface by saying that Alex is not the client's original name. This is more a fictional name that I have chosen to be able to protect confidential information as per BACB code 2.03. With that being said, Alex is 12 years old and he's on the autism spectrum at a level 2. He currently receives 20 hours of in-clinic ABA services a week. The referral behavior that we are targeting is swearing or cussing. Um, it's maintained by access to tangibles, and behavior change is really socially significant and clinically significant in this case because the behavior is interfering with learning, with peer relationships, and with compliance. So increasing that functional communication really allows the client to access items appropriately rather than through the disruptive behavior itself. Okay, so Alex is currently receiving, like I said, 20 hours of ABA therapy in clinic. For the past 6 months, they take place 5 times a week, usually reaching 4-hour sessions with the RBT for direct treatment and session implementation. He also has 2 hours weekly of supervision by the BCBA for caregiver collaboration and treatment oversight, an hour biweekly for parent training to really promote and support that generalization and maintenance in the home. And it's currently being funded by a Medicaid waiver program. So the materials for Alex's sessions include choice boards, visual schedules, to help increase that predictability and to support that communication, token boards, tangible reinforcers, a variety of reinforcers that are preferred to Alex to really not have that satiation happen. We will be collecting data through frequency, through opportunity based data. So, you know, just any data taking, data session data sheets, all of that. So, our outcome criteria for Alex is for him to only engage or to reduce his engagement in swearing to only one instance or less per session for 10 consecutive sessions. So currently, when it comes to this goal, Alex is still in progress as he hasn't met mastery criteria yet. This goal is an ethical alignment with BACB code 2.01 in evidence-based treatment selection. Okay, so before intervention began, our focus was on being proactive. We really just wanted to work on that antecedent strategy. So we worked on providing choices for Alex to kind of give him that control throughout in the session where he can kind of choose what things he wants to do, as well as high probability request sequence and using that behavioral momentum to really get him to engage in that low probability behavior. So this is in compliance with ethical codes 2.01 of effective evidence-based treatment. So whenever Alex engaged in this problem behavior, staff was trained to use planned ignoring whenever he swore to avoid reinforcing the behavior with any type of attention. We also refrained from giving him any access to tangibles, and we withheld those tangibles until he was able to actually engage in that FCR and request those tangibles appropriately. Staff were told to maintain a neutral tone and redirect Alex, maybe going in with the least intrusive prompt first. But the goal was to reduce reinforcement for swearing while maintaining safety and rapport with Alex as well. So whenever he did engage in that replacement behavior of that FCR, we trained staff to be able to appropriately request the item using FCT. And he also received access to the tangible or specific item and received a very specific verbal praise. So the reinforcement schedule was gradually thinned over the past 6 months. And this is all in compliance with BACB Ethics 2.09. Behavior change programs are selected and implemented based on function and data, and 2.12. So benefits of interventions are maximized while minimizing potential harm. So here we're looking at the frequency data for the swearing. As you can see, there was some variability at the beginning, but he did average in baseline between the 8 to 10 instances per session, with no alternative communication taught. So this behavior was, after a functional assessment, the behavior was shown to be maintained by access to tangibles. Um, so yeah, so as you can see in the graph, the swearing frequency shows a very clear gradual decreasing trend in the data where his frequency of swearing has been reducing over the past 6 months due to the introduction of that FCR. So after that FCR was introduced, you can see it, like it's gone down so much. Okay. And this is all in compliance with Ethical Code 2.11, where data is being reviewed and documented to guide treatment decisions further on later on. Progress and next steps for swearing. Okay, so he is currently still in progress. There's been a 70 to 80% reduction from the baseline, but he's not meeting that one episode, like one instance or less a day for the 10 consecutive days. So we do see the clear downward trend, but he hasn't met that mastery criteria yet. So this is all in compliance with Ethical Codes 2.14, selecting, designing, and implementing behavior change interventions, 2.17, collecting and using data, and 2.18, continue evaluation of the behavior change intervention. And this is all supported by the scholarly source of delay tolerance and FCT, reducing tangible maintained problem behaviors. All right. So we have our FCR outcome criteria as well. So we want Alex to be able to independently request preferred items using functional communication response. An example would be like, can I have a cookie, please? Can I have a car? Can I have the pencil? Can I have the Xbox? His outcome criteria is to independently use FCR for 80% or more of the opportunities across 5 consecutive sessions. His generalization criteria would be 70% or more successful FCR responses across peers, clinic, and home. So the data collection for this type of intervention, we're going to be using opportunity-based event recording to measure the percent of independence of Alex engaging in those FCR responses per session. To teach this, we came up with a teaching strategy for the staff. So first, we're going to present the item and allow that pause for an opportunity for him to be able to request. Then if he doesn't engage in that request, then or he engages in that problem behavior, we're going to then model the FCR and follow with a visual prompt, then maybe a gestural to the visual, and then escalate it to a partial verbal prompt. So we're always going to want to start with the least intrusive prompt and work our way up as needed. If he does engage, we're going to reinforce him immediately when he uses that functional communication training, and we're going to have that on an FR1 schedule at the beginning to promote that increase in that frequency of that behavior. And then we're going to be gradually fading those prompts by increasing our wait time, like that delay of the tangible being handed to him from 0 seconds to then 3 to then 5. And then, thin that reinforcement from an FR1 to our VR3 as the independence increases to promote that maintenance. And this is in compliance with the BACB Code 2.09. Treatment decisions are based on effective evidence-supported procedures. Here we see the functional communication response graph. So our baseline averaged around 8 to 10 instances per session, as you can see. And once that treatment that FCT or that FCR was implemented, you can see that a steady increasing trend. Although he hasn't met that mastery criteria yet, he is making headway over there. But he's doing great. But so you can see there's a clear increasing trend that indicates successful acquisition of the replacement skill, which makes us very happy. Okay, so as I said, the outcome is still in progress because he has not met criteria yet. But our next steps will be to continue reinforcement thinning to be able to promote that independence and having Alex be able to engage in that FCR by himself, increase generalization opportunities again at home. So maybe we're making caregiver goals that are helping promote that generalization at home as well, and begin programming for maintenance once that FCR mastery is reached. So this is also in compliance with ethical codes 2.14, selecting interventions based on function and effectiveness, and 2.18, continually evaluating progress and adjusting the plan accordingly, which is exactly what we have been doing. Um, Here you can see our treatment integrity graph across the 6 months. So treatment integrity was measured twice weekly across a 6 month period. Initially, staff, well, we use behavioral skills training. So we had that modeling, sorry, we had that we had that instruction, modeling, rehearsal, and feedback model. And we had a treatment integrity 10-step checklist, which is up on the screen for you to look at as well, to kind of help us stay within, our treatment plan and make sure that we're applying what we're applying correctly. As you can see, it started off with a 70% accuracy before we had that training, like before we trained our staff, and there's been a very gradual increase to the 90s, 95s now. Here we also, throughout the 6 month period, we also collected inter-observer agreement data, and for the swearing frequency we used total count IOA, and for the FCR IOA we used trial by trial IOA. So the dotted line will represent that functional communication request IOA, while that straight solid line is going to represent that swearing. The goal was for 85% or higher in agreement for both referral and replacement behaviors. Okay, so a quick little summary after reviewing this progress review. Some of the barriers that were observed were the original variability in swearing before that FCR or FCT skill acquisition was implemented, or generalization to peers required additional prompting. We noticed that Alex needed a little bit more prompting when it came to his peers than when it did with staff. And then that treatment integrity improvement needed at the beginning. We really needed a little bit more improvement of that treatment integrity to make sure that we were, applying what we needed to apply when we had to apply it. Some of the intervention highlights I would say was the very big reduction of swearing from that high baseline to the low stable levels that we're at now 6 months later. Also that skill acquisition, that very high level of skill acquisition for that FCT or that FCR, that the fact that the treatment integrity in the IOA maintained high and reliable throughout the 6 months is another highlight, at least for me. And the family participation really did improve and promote a very big success with the generalization. So Alex is actually able to request for things in the home as well. So that's how we know we're doing a great job. Apart from that, my service recommendations would definitely include continuing the same hours that he has now. I wouldn't really change anything. I would leave everything as is, just because I feel like until he reaches that mastery criteria, we shouldn't really move anything around. And then once he does reach that criteria, then we can discuss having less hours, or, focusing on that maintenance and generalization. But here are my scholarly references and all the references I used throughout my presentation. If you have any questions, let me know. But for now, this is all. And thank you so much for listening to my progress review. Thank you.